could do. I like when someone calls in and uses a phone number, I can change their name. But when it comes across like that, I just don't know how to change it. So we'll figure
No big deal. I think most people at least know the herd part.
it out. I think so too.
That's why I kept popping in and off, on and off video at the last meeting, so people would say, yes, it's me, and then I'd log back out so I wouldn't distract people. But
Exactly. And then
right.
in closed session, are you doing anything with credentialing or anything else like that in closed session?
Yes, I am. I'm presenting the credentialing package since there wasn't a regular board meeting.
Okay, great. I can right now, Derek. Yeah. All right, let me pull it up as well. Hey, Derek, I'm not seeing the stream on our site. I'm hearing you right there, but where is that coming? Let me just close down the browser. Well, I'm going to close it down. I'll bring it back up again. Okay. What's that? All right, cool.
David sent those over to you.
Okay. I just heard something, but I didn't know what it was. Hopefully it'll come back up a second. Wrong inside that room. We'll have to figure that out at a later time.
Right. Because as many as I go through a microphone, you can hear me, and I'm going to mute it right away. There you go. We'll give you one more test.
Okay. Yeah, it's not coming through YouTube. That time I heard you, Derek, on the YouTube, but I didn't hear me.
Oh, it's because I muted the panel over here as soon as I was done. Sorry about that. But I'll leave it up now.
All right.
We can just talk.
Yeah, let's just leave it up for just a couple of minutes.
Sure.
Here to make sure we got it all fixed. All right, we got it. We're good.
All right,
We're good.
David.
So go ahead and do me a favor. Send that new link to Suzanne.
Okay.
And tell Suzanne saying, hey, here's the new link for the quality committee meeting.
Perfect. I'll send it now.
All right, thank you, sir. Hi, we are live in 3, 2, 1. Dr. Weber, you are live for the Quality Committee.
I'd like to call the Quality Committee on the 14th of January at 1500 or 3 o'clock. I've been told there are no citizens wishing to address the committee. So the first thing we'll do will be consider the matters requiring committee action, which is the approval. But let me just throw in just the minutes that you got had some errors. And especially for like the date said October 1st. I think all those minor things have been corrected by Sean. So
Yes, sir, they have been.
other than that, I'd entertain a motion and a second for the minutes.
This is the move to approve.
Second, by DT.
Discussion, anybody? All in favor, please say aye.
Aye.
Those opposed say no. I've also noticed that Daphne, we appear to have a quorum for the committee, so we can go ahead and take action on stuff. The next thing I have is approval of Tarrant County Hospital District policies and/or plans, and let me tell you about some changes that have occurred with those. Under number 1, the EC 1800 has been pulled for further work. On number 2, the LS 200 interim life safety measures policy has been pulled for further work. Number 3, the LS 300 above ceiling penetration permit program has been pulled for some further work. And the LD 1700 oversight and quality monitor will be presented by Dr. Stevenson instead of Dr. Huckberg. Number 5 has no changes, and on number 6, instead of Michael Hutchberg presenting, Rick Miller will be presenting. And in addition, Rick, I will add you to the Quality Committee as a member.
Dr. Weber, if it would be appropriate to go slightly out of order, do you mind if I gave a brief introduction of Dr. Miller?
No, please do.
You all received the memo about Dr. Hochberg and the administrative changes we would be making. And we've asked Dr. Miller to serve as our chief medical officer. I am incredibly impressed with Dr. Miller on a couple different levels. I'm impressed with his level of medical talent and skill, and to Chuck Weber and Rob Stevenson, he's one of the same ilk. He's a trauma doctor by heart, trauma doctor by care, trauma doctor by concern. He is a guy that when asked to take call, he wants more. And I'm also impressed with his abilities to smile through various levels of adversity. He's a genuinely good guy, and I've really been impressed with him. Dr. Miller joins us from Vanderbilt, and he was along with Vanderbilt for a good number of years. And we had the opportunity to bring him down here to serve as chair of our surgery department. Dr. Miller and I and Dr. Duncan will be working out some of the details, but we like the fact that Dr. Miller is going to stay in his position for the time being, and Dr. Miller will also continue to be a practicing physician. And therefore, the policies that come out of quality and the policies that come out of our board will be interpreted and dealt with by a man who's actually practicing, which we think is hugely important for buy-in from his physician colleagues. So I could go on longer about Dr. Miller because I find him to be a very impressive person. But Dr. Miller will be joining us in this committee, thanks to Dr. Weber. And Dr. Weber, I want to thank you for when we had our phone call and when I told you about the situation, your readily acceptance and concern for JPS. And I appreciate that. So Dr. Miller, formally welcome aboard to the Quality Committee, but you will find the quality members, people like Dr. Simmons and of course Dr. Weber and Dr. Miles. You've got a good share of doctors on this committee, but folks like DT Wynn and Zim Zimmerman and folks like that and Amanda Arazola, you'll find to be a very engaged committee, and you will enjoy working with them. And if you need some of the particulars, Sean will be there for you to help with the particulars and know everything. Sean, you can tell because Sean, of all of us in our pictures, has the largest beard. And he's in a current contest now to figure out how large his beard can be. And we were very, very impressed with him in that regard. But Dr. Miller, welcome aboard. We are thankful and grateful. Thank you, Dr. Weber.
Sean, how long is this beard? I mean,
We're a strong 2.5 inches now.
how much?
We are a strong 2.5 inches
What's your goal?
until my wife tells me to cut it off.
That's a smart man.
Oh my. All right, let's go to the policies that, and not the ones that were all tabled. Daphne, can I just read these and then we vote? There's Sean.
Well, we've got a little bit different grouping this time, so I think probably Dr. Weber, what might be better if you let each of the individuals who's going to present just tell a little bit about them, since they're a little bit different category.
Okay, great. Thank you. Adam, you're up.
Yes, sir. So for the first policy is EC. Excuse me?
I said thank you.
Oh, pleasure to be here. Thank you for having me. The first policy is EC 400. This is Firearms Weapons Management Procedure. This was primarily grammatical with a few minor changes to include prohibition of firearms within JPS vehicles other than folks who are permitted to have that, meaning our enforcement officers. So this one is pretty straightforward and grammatical, and that's the extent of this policy and the changes.
Yeah, why don't you just go on with all of yours and then we'll
all right.
get to the end.
Okay, the second one is EC 700, Hazardous Communication. In this, we tried to make the policy a bit generic in that we removed the name of the previous vendor and made it chemical inventory providers. We also added information on how employees are educated on the hazardous communication plan and where that module can be completed. So that is that policy.
Okay.
The next one is Tarrant County Hospital District Courier Service. In this one, we clarified that transportation will not be moving emergent patients. They will move only non-emergent patients from our outpatient facilities and to our hospital and vice versa. So that's incredibly straightforward, in that we have an outside service, of course, to manage our emergent patients. And then the last piece had a few more changes. This is EC 2900 on our emergency eye wash and shower stations. This is in line with our Joint Commission surveys that we had. And we made some changes to the weekly, monthly testing logs. We noted that facilities engineering inspects and tests all eye washes and showers, and that documentation is tracked in that area. We removed the eye wash bottle verbiage in that those are no longer allowed by ANSI or code. We moved the water temperature testing component in that it's a work order. Does it feel warm? Does it feel cold? There's no regulations around temperature specifically. We updated the training section to define who's responsible for making sure employees are trained on the eye wash stations, and it's departmental level, and they are responsible for logging that at the department. And then we removed the annual testing log. That was removed from the procedure because this is kept in a CMS system, meaning the tracking system, work order system within facility engineering. And that is the extent of these 4 policies.
Okay.
Very exciting.
Anybody have anything they want to say about these? And if not, then I'd entertain a motion to approve 400, 700, 1900, and 2900.
Move approval. DT.
I'll second. This is Keith Simmons.
Second by Steve. Any discussion of these? All in favor, please say aye.
Aye.
Those opposed, say no. I'm going to take a little bit of license here. At the beginning, I should have said this committee meeting is virtual because of the Governor Greg Abbott's and Attorney General Ken Paxton's meeting suspension guidelines to view this meeting on live stream online. Okay, the next one that I have then is Rob, LD 1700.
Thank you, Dr. Weber. I come before the committee today to seek approval for the routine renewal of LD 1700. There were minor wording changes that were not substantive. Just to summarize, this is a policy which states that we will be monitoring and reporting the results of outcomes from not only our physician groups and others that provide contracted services to the hospital district, but it's not a substantive change. The one action that will come out of following this policy in the future is that we will be bringing forward to the Quality Committee in coming months, thanks to Dr. Weber's approval, results of these measures from our various contracted groups as well as from various service lines in a claim.
Great. Anybody have any questions for Rob about this one? If not, I entertain a motion and a second to approve it.
This is Dorothy, move approval.
Second, ET.
Discussion? All in favor, please say aye.
Aye.
Those opposed, say no. Okay, the next one I have is NPSG 200 color-coded wristbands. Dina Dent.
Hi, good afternoon, everyone. Thank you for your time so I can review and present National Patient Safety Goal Policy 200 color-coded wristbands. This is a joint commission policy, a nationwide policy that was adopted by Texas Health Association in 2008. The only updates with this policy are grammatical and for formatting. This policy allows for consistency for patient care based on diagnosis and care, the color of the wristbands the patients wear. So if our staff work in another hospital in Texas or outside of Texas, the standard of care is consistent with the color of the wristband. I ask for approval with moving forward with National Patient Safety Goal 200 color-coded wristbands. Thank you.
Dina, thank you.
Does this comply with our CEO for the color scheme?
Oh, God. You're mean, DT. I mean, you know Robert and I are both red-green colorblind.
Exactly. So if whatever color it is, I'm going to approve it because it's going to look really good.
Yeah. You're beating up on the handicapped here, man, you know? Okay. Entertain a motion and a second for the NPSG 200 color-coded wristbands.
This is Zoom. Move to approve.
This is
Second.
Second.
All righty. Discussion? All in favor, please say aye.
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 Those opposed say no. Motion passes. Rick, RI 1700 informed consent policy.
Thank you, Dr. Weber, and thank you, Mr. Early, for introducing me to this wonderful board. It is an honor and a privilege to be in this position, and I vow to do the best that I can, serving as both the chair of the Department of Surgery and now my new position as Chief Medical Officer. I have much to learn, and I'm excited about it, and I look forward to working with all of you. So thank you very much. I will be presenting the minor additions in informed consent policy. There are a few grammatical changes. We also removed the paragraph on minors, as we now have a separate policy for informed consent related to minors. Additionally, there's the informed consent procedure, where the informed consent has a specific definition, and there were very minor editorial and grammatical changes. So I ask the board for approval for the informed consent policy as shown.
Comments or questions for Rick? Rick, I do have one for you. What do we use as the cutoff date between adolescents and adults? Do we do it by weight? Do we do it by age?
It's age. And there are some minor issues with this. It's 18. However, as a level 1 trauma center, we take care of all ages. And we have taken care of patients that are significantly less than 18. The big issue is that some adults feel uncomfortable taking care of quote unquote children, even though their body habitus is of an adult. And so there are times after discussions that we have to transfer these patients to cook. So it is 18 here at JPS, but trauma patients are managed below that, and we do the best that we can. We keep most of the patients, but if it's a cardiac problem or a neurologic problem, occasionally we will transfer them.
Okay, great. Any questions for Rick? Motion for approval and a second.
Move for approval. CT.
Dorothy.
I didn't hear the second.
Dorothy.
Oh, hi, Dorothy.
Hey there.
Discussion? All in favor, please say aye.
Aye.
Those opposed say no. Not hearing no, motion passes. Next is consider performance improvement reports updates not requiring committee action. First is PSI 90 and the quality scorecard update. Rob Stevenson.
Great. Can I have the slides, please?
I guess that would be no.
There we go. Can we have the slideshow? There we go. Perfect. Next slide, please.
Who you got working the clicker?
Yeah.
All right.
Okay. Great. Thank you. I appreciate the increase in size. It helps me. My eyes are getting old. So once again this year, PSI 90 is our primary quality goal, and so we're going to keep very close eye on it, of course. We're off to a very good start this year. We have so far had, through the first 3 months of first quarter of 2021, we have had 7 total PSI events. So far our PSI 90 overall score is 0.77, which is in stretch range. So we're off to a very, very good start, and hopefully that will continue. And one interesting thing, of course, is that this has paralleled this period of time, especially December, has represented, truly our most difficult month in terms of overall COVID volume. So we've done well, despite the fact that we've had a lot of COVID around. So a lot of adjustments have been made since the first time that we had a big surge of COVID, and we're not seeing, for example, as you can see, the pressure ulcers, which we had seen back in the earlier phase with COVID disease. So we seem to be doing better with keeping the pressure ulcers down and keeping pressure off the bottoms of these very sick patients. So otherwise, things are going along quite well, as you can see. Next slide. You can see our first 3 months there graphically displayed. So we had a bit of a tough October, but we followed it up with very strong Novembers and Decembers. That October was particularly challenging because of a single case of postoperative sepsis. So as we've talked about before on this committee, this is a risk-adjusted weighted measure of patient safety harm events. And some of them are weighted really, really strongly. And one of those that's weighted very strongly is postoperative sepsis. And we had a postoperative sepsis in October, which was really the result of driving our number high. But all three of those months really by any standard are good. Now, remembering that a score of 1.0 represents the rate of events that we would expect to happen based on the severity of illness in our hospital. Anything under 1 is good performance. So even that first month was in the good range, not up to what we're hoping for in terms of our threshold, goal, and stretch, but still good performance. And then the subsequent months have been very good performance. So we're very pleased with this beginning. Next slide, please. And that's just a detail of the various different harm events. As you can see, we've actually had an interestingly high number of postoperative hemorrhages and hematomas. So we're going to be digging into that a little bit more just to make sure there's nothing that we can do to improve. And then you can see that one postoperative sepsis sitting there. Next slide, please. This is the remainder of the quality scorecard. The surgical procedures are still too recent, just being 1 quarter into the year to have useful data. We are off to a bit of a rough start in CAUTI and CLABSI, as you can see both. So what the numbers that are reported there in the rightmost column, the top number is the standard infection ratio, the SIR, and so 1.0 again is what you would expect based on the types of patients we're seeing and the severity of illness. So both those numbers are pretty high, and they do represent almost entirely cases that we're seeing in the COVID ICU, and in part because of this, also because of some really good tracing activity that infection prevention has been doing in that area. We're doing a very hard look at all of the procedures there to try to mitigate the risk of nosocomial disease transmission in our COVID ICU. So some of this may be a bit unavoidable because these patients are very, very, very sick and require tremendous, tremendous aggressive care to give them any chance of surviving. But we absolutely have to take every step possible to try to mitigate this, these kinds of infections. So, and we are doing that. Next slide, please. Okay. I believe we go on to this. I think Robert, if I'm not wrong, Laura has taken ill and is not available for this presentation. Is that correct?
Yeah, we were kind of going minute by minute on that, and she texted me about 3 minutes before the meeting and said she just is feeling so much under the weather, it'd be really difficult to make the presentation. So, and that's going to be very specific to her because it deals with language services. So if we could, Mr. Chair, we would propose that we would postpone that to the next quality meeting and allow her to make that presentation, if you don't mind.
Doug, that's great. Thank you. I hope.
Thank you, Robert. Appreciate that. Thank you, Chuck. Appreciate your understanding with that. Okay, so we'll just skip through this. All right, now we move on to Innovation Corner, I believe. Oh, sorry, COVID update. Yes, thank you. Let's do our COVID update. So we're in a really tough spot here in North Texas in terms of COVID. And, my hope is that it's the darkness before the dawn as we have an opportunity to, vaccinate our population. And I know Mr. Early will speak about our efforts in the county's efforts with regards to getting vaccine out to folks. But as you can see, we are seeing now more cases of COVID in Tarrant County than we have ever seen before. So you can see that spike back in July. That was the last time we thought we had a huge surge back in July. But you can see it's just absolutely dwarfed by what we're seeing presently in Tarrant County. And that is reflected in high hospital volumes really all over the region and all over the state. Next slide, please. As you can see, we thought that we had a huge spike going in late March, which got us all to shut down everything for a while. Then in July, when it came to the Sunbelt states, we thought that was a huge spike. And now you can see what we're facing now. Again, a tremendous surge in cases all across the country. Next slide, please. If you recall, way back in June, I brought you data from around the world, which showed how a lot of other countries had managed to stem off the disease. And, you know, the absolute numbers are low. Canada's only had 600,000 total cases, but you that fatigue is playing a role in this. I can speak to this a little bit directly. I actually did make it up to Canada in November to see my mother, and I drove past a bar, and there were all kinds of young people waiting outside. They were masked outside waiting to get in, but once in, I'm sure they're drinking and then going about their business. So I think a lot of the same challenges, you know, of people just getting tired of this really miserable situation is really leading to, you know, a breakdown of what we need to do to try to control this really worldwide. Next slide, please. Commensurate with the increase in cases, we're now seeing an increase in deaths that is getting close to paralleling what we saw in the very early days of COVID, when we really didn't understand anything about this disease or how to treat it. So, you know, the treatments are all better now, but now just simply with the sheer volume of cases, that mortality rate is beginning to accelerate. Next slide, please. And you can see here as well, even in our county, we're beginning to get up to the levels of mortality that we saw during that July-August spike. Next slide, please. Here's our hospital volumes. We're now at the highest number of COVID patients at the hospital that we've had. Today it's over 180 COVID patients, and that represents a pretty darn big chunk of our beds, I can tell you. So the burden of this is pretty substantial on our inpatient resources. Next slide, please. So what have we done to respond to this latest surge? Well, fortunately, the vaccine came out, and we've launched an aggressive program to vaccinate our employees and our high-risk patients. We've halted elective surgery. We need to preserve resources for managing COVID. We've needed to divert staff to helping out in with COVID care and non-COVID care when we have to divert some of our usual nurses into COVID care. We closed the Jps Surgery Center in Arlington, which provided a staff influx as well as an influx of equipment that we've needed for our surge units. We've worked aggressively with state and private agencies to obtain contract staff. We've aggressively sourced PPE, vaccine, therapeutic, and testing supplies. We actually, based on very high volumes of behavioral health patients testing positive for COVID on their way into Trinity Springs Pavilion, we've actually opened a COVID-19 dedicated inpatient psychiatric unit. We're now providing monoclonal antibody therapy to higher risk COVID outpatients in conjunction with our outpatient case management program, which continues to function very well. And again, in association with that program, we're now also initiating outpatient remdesivir therapy. So remdesivir is one of the therapeutics that has been shown to be effective in preventing people from needing ICU care with COVID. And we're now able to offer that therapy to some patients on an outpatient basis. Now, all these patients are starting their remdesivir therapy on the inpatient side. But then if they're doing well, then we can complete their course of therapy on the outpatient side and get them out of the hospital a little bit more quickly and into the care of our outpatient case management program. So all that's been very, very successful. Robert, do you want to say anything about our vaccination efforts?
I do, Rob. Thank you very much. If you all will put my slides up. Actually, I just said that to scare him. I don't have any slides. I just wanted to scare Sean for a second. Let me give you guys an update on where we are with vaccines, because I'm incredibly proud of Joy Parker and Doug Chung and Jill Farrell for the expediency, the efficiency, and the manner in which JPS has conducted itself through vaccines. To date, and we don't have our totals in today, we've given over 10,480 vaccines. That's split between employees and patients. we've provided some 4,000 almost 5,000 employees have gotten their vaccines, and some 4,600 patients have gotten vaccines. We started last Thursday providing vaccines to those coming back in for their second dose. We've done about 812 of those at this point. The thing that I am most impressed with JPS is now we are a very well-conditioned machine in providing a little over 1,000 vaccines a day. That hits our capacity on two levels. One, it is, to Rob's point earlier, with that many COVID patients being in beds and making sure that we are still taking care of routine flu and the routine nature of trauma care and regular hospitalizations and clinic visits. When we establish the COVID vaccine units, that's taking nurses and techs and staff members off of floors. So the 1,000 plus a day that we're giving really reaches the maximum of what our facility will allow, and it hits the maximum of what our employee capabilities are. So when people say, well, why is JPS not giving out more? We are giving out as much as we can possibly provide with the staff in the space. I think a lot of people compare this vaccine to a flu vaccine, which there is significant differences from the amount of social distancing you have to have coming into the room and the 15-minute observation time period with social distancing afterwards. That's a space requirement. I have had very positive conversations with our county commissioners and county judge about JPS Clinics. We are using our clinics to make sure that we're vaccinating as many of our patients as we can. We've put an emphasis, because of health disparities, we've put an emphasis on our Como area and our Diamond Hill area and our Stop 6 area, so that we can attempt to deal with the unfortunate health disparities that are pre-existing. We've also looked at our most vulnerable of patients, one with challenging comorbidities that we think, if we vaccinate, could help them deal with the aggressive nature of COVID when you have a comorbidity of challenge, such as diabetes or obesity. So I'm really proud of what we're doing in the clinics for our patients. I'm proud of what we've done for our employees and our patients in our main campus. Our main campus is primarily used for our Pfizer vaccine. As you well know, Pfizer needs to be stored in -80 degrees, and we have the cold storage on campus to do that. We're using the Moderna vaccine mostly in our clinics, and that is running quite well. We have also worked very hard at making sure that we don't have excess vaccine and making sure that it's being used in a timely manner. I apologize for the analogy, but my staff knows I speak in analogies. Running a vaccine program is much like being a grocery store, in that you want enough bread on the shelves for people to buy, but you don't want enough bread that it's going stale. You also don't want too little bread that people are frustrated they can't buy in your grocery store. Very similar with vaccine. You got to make sure you've got enough, and you got to make sure you have enough for a continued period of time, such as 5 to 7 days. At the same time, you don't want to have 20,000 or 30,000 vaccines sitting around. So in the last 14 days, we have provided some 8,500 vaccines to the Arlington facility. That facility right now is one of the most efficient facilities that the county has, giving almost 2,000 vaccines a day. So we try to do all we can to help anybody who is a purveyor of the vaccine. We try to get it to them if we can help. And so we've done that. So we're trying our best to help the community. We at JPS want vaccine into any arm that meet qualifications that we can get it to. So Mr. Chair and Dr. Stevenson, that pretty much is an update from our vaccines. And I'm happy to answer any questions, but I will tell you that Karen Duncan, and again, Joy Parker and Jill Farrell and Doug Chung have done an incredible job of managing our vaccine program, and due applause to all 4 of those people.
I have a question for you, Robert. Can
Sure.
you comment about the homeless getting vaccines?
Yeah, we have, and I apologize for leaving that component out. It's our newest component. We are aggressively now doing vaccines at our True Worth facility, which is pretty much the epicenter of Tarrant County's homeless population. We realize that there is a homeless population throughout the county, but we are doing a lot of work at our True Worth facility and making sure that we get vaccines out to the homeless. We've also, Dr. Weber, done, I think, an exceptional job of getting vaccines to the jail, not only for those that take care of the inmates from a healthcare standpoint, but also the inmates themselves. One can consider that Tarrant County does not want an outbreak in a closed environment with a vulnerable population. So we have done an excellent job. Karen Duncan seized the opportunity to get vaccine to the jail. So from the jail to the homeless population, JPS is administering vaccines to those that may not ordinarily get it.
All righty. Anything else, Rob? Anybody got any questions for Rob or Robert? Okay.
We are, Dr. Weber, the last thing on vaccines, we are following the protocols of the state for the 1A and 1B categories. So 1A obviously is your healthcare workers, and your 1B category are those over the age of 65 and over the age of 18 with comorbidities. So we have kept to those standards. We have incredible, I think, relations and communication with the state on how to administer, and the state has been very good at rewarding JPS with getting it the vaccines that we need. So it's actually worked, in my opinion, very well.
So, okay, are we ready to move on?
Yeah, go ahead, Rob.
Okay, great. So for individual,
one question. Sorry, I was trying to get off mute.
Go ahead, Amanda.
Hi. Yeah, just in relation to the vaccine, as you're seeing everything, I know Diana with communications trying to get up the Spanish language services for the information through that. With MyChart, I know that's been a discussion previously that MyChart has some language options. These were some questions I was going to ask Laura today. So has that, can you explain if MyChart is available in Spanish for them also, so that that population is also receiving that information signups? Because we have heard the wait times on the telephone, and with good reason, are long hours. So just wanting to circle back with that about the MyChart.
Two things, Amanda. One, I'll check on the MyChart capabilities to make sure that I'm speaking correctly. The other thing that we are doing, and I think maybe Dinah Pritchard or others may inform you, so I hope I'm not repeating it, but we've asked our primary care doctors that have relationships in areas such as Diamond Hill, where we have a large Hispanic population, or the health disparities that we see at Stop 6, we've asked our primary care physicians to begin to identify and ask those people to come in and get their vaccines. So we are trying hard to have an outreach in addition to the signing up. So if you would afford me the indulgence of allowing me to ask Laura the question about MyChart, I will do that so I don't answer it incorrectly. But we're trying to aggressively do it a lot of ways. One, people calling in. We're also working with the county with the list of people that they have, because some of the people that they have on their list through county facilities, some of those people are our patients. So we're affording block time for part of our days, because we know that there are going to be some unfortunate no-shows for people getting vaccines. We're trying to fill those slots with people that are on the county list. And we're trying to work with the county to identify the potential of either them being a JPS patient and maybe having a medical record here, but also trying our best to look at health disparities and get out to them. So it's twofold. One, trying to push to them, and two, trying to get them in. So I'll definitely check with Laura Burnside to make sure, so I can get your answer. But we're gonna do that very thing of both ways. And it is, you're right, Amanda, it is slow and it is challenging, and all those calls are coming in at one time. The luxury for us is obviously we're a 24/7, 7 days a week operation. So we see a pickup in those calls when the Arlington facility may not be doing it on Saturday, or county may not have some of the facilities open. So we are trying to work hard. I'm also understanding that Texas Health Resources is working with the county to open up mega centers and large facilities throughout the county. I think if you've talked to Commissioner Brooks or Commissioner Allen, they will tell you that the goal is to vaccinate 2.1 million people in Tarrant County, and that's our entire population. So that would be our goals as well, in whatever role we can play.
Yeah. Okay. Thank you.
You
Ron,
bet.
I have one question on, I'm getting a lot of calls, but one of my questions is the folks that now they see is beneficial, the 65 and older, to be treated at JPS. So is there a wait time, a long time for them to get in with a provider?
I don't want to put Karen on the spot, but I would refer to I know Karen, I want to refer to Karen and make sure that what we're doing from the community clinic standpoint. But Amanda, typical of let me pause for a second, Dorothy, and tell you, Amanda, that my chart is available in Spanish. Now, I've not been on it and looked at the Spanish capabilities of it, so I don't know to what extent that is helpful, or do we have things that are not as viable on there? But I know it is available in Spanish. So we'll go back and make sure that it is convenient and easily used, and the directions to get on my chart from a Spanish standpoint are there. So Karen, if you don't mind, would you talk about Dorothy's comment about those over the age of 65 wanting to try to get vaccines through JPS?
So just for clarity, Dorothy, are you asking about those who have established, are an established patient at JPS? Or are you speaking about someone who may want to become a patient at JPS?
I think I'm asking you about the ones that want to become a patient at JPS, because those are the ones that have been calling me. It isn't the ones that have are established with JPS are going through my chart, but they end up going through the number you told them to call because they can't make it on my chart. So it's new patients that now feel like they want to be a part of the JPS system. So I just told them that, that if they were trying, that it was a good time to do it. I just didn't know if there was going to be a long wait. Okay.
So yeah, we actually had that conversation this morning. So we have seen an uptick in the number of individuals who have called and said they want to become a JPS patient.
Okay.
We treat them as we did before the vaccine. We make them a new appointment. At that point, if they're asking to receive the vaccine, we allow them to come in and receive the vaccine if they meet the 1B criteria.
Okay. All right. Thanks.
But we do want them to show up, Dorothy, at their new appointment.
Okay. Well, I'm kind of working with the ministers out here and the Senior Citizen Center. So I know with those two, they will be showing up. Though that's critical that they don't make an appointment and not show. So I'm working with their pastors and the senior center to make sure that those that make appointments get there. Okay.
Yeah. Dorothy, I know of your role in the community. I know of your strength, and I also know of your persuasiveness. When those people call you, will you tell them that we are really good at giving vaccines and we are really good at primary care after that? So we would be delighted that they would be long-term patients of ours, and that would be the greatest thing.
Yeah, that's what I meant. We want them to show up for their new patient appointment. I think they'll show up for their vaccine. We just need them in for their new patient.
Well, I think that one of the folks that I sent over there is the one that's really pushing for folks to transfer. Her experience was wonderful. So she is the one that is pushing and having folks to call me. So that I'm not selling it. It is the person that used our service that is so happy that she's telling folks that's where they need to go. So,
Oh, that's great.
Good. That's great.
I have a different issue. Maybe it may be just a process thing. A few people call me and they actually try to call or show up and was told to go ahead and register through the My Chart. And if they are not patient, they couldn't register. And then they sent their kids to the medical home and they were told to leave the form there. They left the form there. Somebody will call them back. Never did. And so I don't know what happened to those files, the form that they filled out. And when they called me, I said, get on My Chart, because if they enter into the system, then it should be on My Chart. They could not get authentication to go onto My Chart.
Okay. DT, if we can take this offline, I'll get Joy involved in this, because these are the kind of things we want to know to, perfect our process.
But Joy, Karen, yesterday I helped somebody try to make an appointment, and on my chart is telling them to go to that number, to call this number. They are not allowing them to do straight to my chart. Now I don't know if this person had a primary care, so I told her, well, send your message to your primary care. But when you go to My Chart, it just refers you to your number to call to get your appointment. Okay.
Okay, I will take a look at that, because I don't know, on your side of it as a patient, you do have to activate My Chart, and you have to go in and set up an account. So
yeah, these already had a My Chart.
My Chart account. Okay.
Yeah, but when you go in to try to schedule, it's a message come up as of yesterday telling them the number to call to make the appointment.
Okay, good. That's not what we want. So thank you to both of you. We'll take a look at that.
No, I agree. There are process problems. And would you be kind enough to just give us an update on those at the next meeting?
I sure will, Dr. Weber. I'll be glad to. I'll have Joy come in and give that.
Please. Anything else that? Okay, go on to the innovation corner.
Thank you, Dr. Weber. I'd like to, we have a couple of interesting presentations, I hope, for the board, for the committee. The first one is from our, please go back to the previous slide. The first presentation is from our emergency services. Now, what I wanted to do was to bring them in so that you can, so that the quality committee can understand the work that they're doing, the volumes that they're seeing, the challenges that they're facing, and some of the great work that they're doing to help take great care of our patients. And so, because I think, especially as we go forward with planning for the future for JPS, I think understanding the magnitude of what we see is a very important element of that. And on top of that, I wanted to have a chance to recognize some really great work that's going on down in our emergency services. So without further ado, I will turn it over to them.
So first of all, thanks, Rob. It puts a lot of pressure on it by stating that it's going to be an interesting presentation. So I'll do the best I can. You know, obviously, after serving as president of medical staff for the last couple of years, or for 2 years prior, and getting to know members of the board, you know, I, like many of you, sure wish this could have been able to be presented in person, but obviously the times that we're in don't allow it to be able. But today I come with my more permanent hat on, and that's chair of the emergency department, and I'm here with Jesse DeWard, the executive director of emergency services. And what we wanted to do was take this opportunity to share an update of our ED and really all the work being done by our frontline staff and providers. So we'll jump into the next slide if that's okay. I always like to start with a little bit of where we've been. You know, Dr. Weber, you've been around as a member of the board for a while, along with several members on this board, and just kind of want to give some perspective of what it looked like 10 to 12 years ago. We had seen pretty exponential growth from that 2008 fiscal year, being able to fix some of the efficiencies in the department, and had grown to where we were talking through volumes of nearing 130,000 visits per year before faced with what we were faced with last year. Go ahead to the next slide. So this is kind of really an interesting timeline as it ties to our year in review, really. So in January, COVID was but a blip on the radar in a lot of the news stories. And in our emergency department, we had set at that point our highest month ever in terms of volume and patient encounters. So we had over 11,500 visits that first January. Kept on pretty busy in February, and then really by the end of March, COVID started to rear itself and saw a precipitous decline in volume on that April 2020 time period. This is really the time when lockdowns, started to occur. To flatten the curve efforts, et cetera, all started to be emphasized and pardon me, sorry about that. Saw a precipitous decline in our volumes over April and with some increases over the next several months to building back to a steady state. I can go to the next slide. Just again, a little bit more historical context. These were our left without care and treatment complete. In fiscal year 2008, it was over 12%, and we had seen, through efforts, both of our nursing staff and leaders and our providers being able to really drive that left without being seen rate down into low single digits. But obviously we ran into a lot of the same issues as it tied to our 2020 year. So if we can go to the next slide, I'll turn it over to Jesse.
So just as Dr. Schrader shared, we were challenged with some our left without being seen in January with our very high volumes, and then as we seen a dip in the volume with COVID, that also that it also opened capacity within the hospital. We had a couple of really great months of being able to see patients coming through the ED, and then really when we had that first spike of COVID in July, and really since have continued to be challenged with increasing numbers of left without treatment complete. Next slide. And one of the most proximate issues that tend to follow each other is as our boarding times increase, our left without treatment complete numbers increase, and that both true here last year. As you can see, in January we had very high boarding times. Those began to come down as our volume dropped, and then again as COVID came back and surged, and really as it stayed, we've been quite challenged with the boarding times in our EDs. Next slide.
So I thought I'd touch on, really what we saw as we tried to, as we had patients come into the emergency department, what our admissions looked like. We keep track of two different pieces. One, we keep track of what our raw number of admissions look like, as well as our overall percentage. And as you can see, what I find pretty interesting is we'd always really sat around a 22 to 23% admission rate. And in April, and I think this was reflective of the news, what we saw in the news, but in April, we saw it go up to about 25%, and it's really sustained itself at a 25 to 27% range. This is pretty consistent with what a lot of the messages were from our MedStar colleagues and that were shared by our news colleagues, where I think people waited to seek out care in an attempt to avoid going to the emergency department. But at times now, what we're seeing is they're presenting, quite further along their pathway of illness. And so we're seeing sicker patients. It's the emotional toll that obviously takes its toll, and therein lies part of the issue as it comes to even a lot of the boarding issues. Is the patients we're seeing, the ones we're seeing, really are complex in terms of their medical illness. You can go on to the next slide. So what we sort of like to be able to share is we want to make sure that we can reflect what it looks like in terms of our operational efficiency, to make sure that we're taking advantage of every care space. And so one of the ways we approach this is we look at how many visits we have per care space in our emergency department. When you are able to refer to the data, EDVA is an Emergency Department Benchmarking Alliance. It's a national organization to where you share anonymous data in to kind of see where you set where you set in compared to other emergency departments. So as you could see, we have about almost 2,300 visits per care space, and what we see from our like institutions of visits, EDs that have over 100,000 visits, is they're really 1,500 to 1,600. So to put it another way, just in terms of being able to think about this, on average, our colleagues that are like size see about 6 patients per care space per day. Another way to think about that is by the time you walk in, you get a bed for about 4 hours in your length of stay and are able to be seen, subsequently discharged, and be able to go home. In December, if you measure that impact of boarding, where those beds are no longer available because they're being seen by a patient who's waiting for an inpatient bed, of the remaining beds we have, we see just about 12 patients per available care space per day. So what that tells us is that we're, again, through the credit of our frontline staff and our providers, they're seeing patients in chairs, they're meeting patients in hallways, they're meeting patients in the waiting room, just to be able to initiate that care before we can get them to care spaces. Next slide.
And then the last slide is really about our patients' experience. And this we wanted to really highlight again the strong work that our staff has done through this pandemic to continue to retain and actually meet our patient experience goals. We are the areas that we are struggling with, unfortunately, is really around family involvement. Our ED really related to the challenges with space and with a disease like COVID that really requires social distance, has really prevented us from allowing visitors with patients, other than in certain circumstances where they are needed for the care of that patient. And so that has been reflected in our scores, but we do want to celebrate the improvements that we've made and continue to work on those that we can do better on in the future.
So, Dr. Stevenson, that summarizes our report. We're happy to answer any questions if Dr. Weber or any of the committee members have any.
Am I unmuted for a moment?
Yes, sir.
Yeah, okay, great. I think to put this into context, it's worth noting that basically per care space, we see twice as many patients roughly as there were at least 40% more patients as the usual emergency department. And when you take into account the fact that we're always boarding a large number, and there are many, many reasons for that, and we're going to continue to talk about throughput, and actually there will be some presentation on throughput as part of our QAPI presentation next month. But the ED is doing yeoman's work with the resources that they currently have. But I think it would be fair to say that those resources are strained. But despite that, they are powering on and doing really everything they can to take outstanding care of patients. And I just want to commend Chet and Jesse for all their leadership and for what they've been able to achieve down there. So I just want to thank them for that. And now, obviously, I turn it back over to you, Dr. Weber.
No, you're Chet. Good work. Okay.
I only wish I could take credit. I think the providers and staff really at the front lines are the ones just constantly pushing themselves to the limit. So I appreciate it.
Yeah, my standing remarks are thank you, because
I have a quick question, Chad. For the average length of stay at 4.something days, is that because of the severity, or is that because of lack of transition care clinic or the scheduling for the next visit for them to be seen that keep them staying in the hospital longer?
Mr. Wynn, I'm sorry. Do you mind repeating?
I'm looking at the average length of stay, and is that because of the severity of the condition, or is it because sometimes they stay longer because they have no place for follow-up to make sure that the treatment or the drug therapy or follow up the next day or something like that? Is that?
Are you referring to the ED length of stay or the hospital length of stay?
The ED length of stay.
Yeah. So we're right about 4 hours, and that's I think we really sit right below the national average, and a big piece of that, DT, is that if you kind of walk through, let me just say it this way: it's related to severity, because at the end of the day, these are patients that are coming in, getting lab evaluations, getting radiologic imaging, potentially getting treatment, and then either being discharged home or coming into the hospital. I think it's a little bit like fast food. We come in, there's a pretty extensive workup they get, and I think, actually, to be honest, to be able to do that all in 4 hours is pretty amazing.
Okay, that's good. Could you go back 2 slides with the average boarding time? Because we don't have an updated one. 2 more back, I think.
Yeah, it's got the red bars.
Right. Well, I'm good there. I thought I saw a different number, but I'm good there. Thank you. Because we don't have the updated one. We only have up to September. That's fine. Thank you.
Oh, I'm sorry. My apologies.
All right. Anybody else? Any questions for Chet? Chet, thank you very much.
Thank you, sir.
Tell everybody down there that the board thinks very highly of what you guys are doing.
Appreciate that. Thank you, sir.
Thank you, Chet. Appreciate it. Thank you, Jesse.
All right.
Sorry, go ahead.
Innovation Corner, Rob.
Yep. So some of you may have heard an interesting news article, I think it was early last month, regarding some really innovative things that we've been doing at JPS to manage patients on ventilators who have COVID-19. And tremendous credit goes to Jim and his colleagues in respiratory therapy for their innovative thinking, and it's allowed us to manage these patients in a much safer way than before. And I turn it over to Jim for his presentation and comments. Thank you.
Well, thank you, Dr. Stevenson. For those of you who are not completely familiar with respiratory therapy and what we have done over the past several months, just kind of as a recap, back in the early part of last year, we recognized that we were faced with a respiratory related disease that was going to require a combination of significant amounts of mechanical ventilation and significant amounts of protective, personal protective equipment, PPE. And as we started looking through our needs for meeting this challenge, we were faced with fairly limited numbers of ventilators and fairly limited amounts of that PPE. And so we started looking at opportunities to meet the challenge. It occurred to us that many times in our environment, we use Bluetooth technology to power our radios. Many of us have earbuds with that we use with our telephone, so we can have personal conversations or listen to music without irritating our neighbors. And we got to thinking how that technology might be able to be leveraged in meeting the challenges we were facing here in the hospital. And so we got a hold of the manufacturer of our ventilators and had some discussions with them, and they seemed to take those ideas and run with them. And within just a few weeks, we're able to develop a software that would work with mechanical ventilators and allow Bluetooth access from a computer across the room to make changes to those ventilator settings. Those pieces of software and hardware were put together and tested at two of the major hospitals in the United States, two major research hospitals, Northwestern University and Mass General in Boston, and they showed that it works really, really well. So now, over the past several months, we at JPS have, because of the efforts of the board, been able to obtain the specific model of ventilators that was necessary in order to make this technology work for us. The ventilators we had at the time this whole thing started did not allow for that technology. And so we've been able to get that technology, those ventilators here, because of the federal government's allocation limitations of the ventilators. We just received our last shipment of that particular model of ventilator in December. We are now working with our IT department to work through the IT security issues to get that technology up and running. Because of some of the challenges with people hacking computer systems, our IT department is very sensitive about this sort of access, and we respect that, and we're working very closely with them. The benefits of this technology, though, is that it allows us to, first off, access those rooms where patients are in isolation and requiring a significant amount of PPE. We can access those rooms, make these ventilator changes without going into the room and wasting PPE. It also allows us to do so quicker, because if we're outside of the room, we have to don that PPE before we go in. It allows us to make that ventilator change and intervene on the behalf of that patient much quicker. And so we're very pleased with some of the benefits that we're able to get out of this, and you know, also from the fact that we were able to come up with an idea that is used at other hospitals, made a very positive impact on patient care in other parts of the United States due to things recognized and challenges that were identified here at JPS. And so those are some of the reasons why we came up with the idea, some of the challenges we faced that kind of precipitated the discussion and the ideas. And we look very forward to, within the next very short time, being one of only a small handful of hospitals in the United States that are using this technology. So that is the extent of my presentation. If you have any questions, I would love to answer it for you.
I have a question for you. This is DT.
Yeah.
Are you talking about the Omni tool?
Yes, I'm talking specifically about the Omni tool. The Omni tool is software that it is upgraded software that's added to the ventilators that are available, the Puritan Bennett 980 model of ventilator. It's added software, and that has been added to all 18 of our 980 ventilators.
Right. What is the concern around the Bluetooth? Because the Bluetooth only have a 30-foot range, unless you have a hacker sitting next room. Is there anything else beside that for security concern?
No, I think for the most part, this is a very easy to overcome challenge. I don't think it's going to be a problem at all. As I mentioned, we just in mid-December received our last shipment of these ventilators. The OmniTool software was uploaded on all 18 of our ventilators the week between Christmas and New Year's. And so I don't think the security challenges are going to be an issue for us at all.
Okay.
Actually, DT, this is David. Let me just jump in. The security challenge isn't on the ventilator. The security challenge is on the PCs that are running the Bluetooth change. And here at JPS, we've turned off Bluetooth as policy on every PC across the organization. So we're trying to figure out from a global policy, a GPO perspective, when we push out the change to allow for Bluetooth, to ensure it's only in those areas. And that's the concern, and that's the challenge we've had, because all of our PCs are imaged generically. That's become a little bit more difficult for us to do, but we're on it. We'll hopefully have that fixed very quickly.
Is that to prevent them from putting a device in there to copy stuff?
Yeah, absolutely. So we disable USB ports as well as Bluetooth, so that people cannot take away data from the systems. You got it.
Okay, thank you.
Any other questions for me?
Great idea. Can save lives there. Thank you.
No, I think it's a great idea. Congratulations.
Well, thank
Especially
you
for all the work you did to get these ventilators in functioning for our folks.
And we very much appreciate the efforts of the board to provide those ventilators for us. As we approached this issue back in January, we had a significant number of ventilators, but they were starting to get a little older, and we had planned on making a request to replace some of them a little bit later in the year, but just because of everything that happened and the challenges we were facing in the short term, we were able to bump that purchase up earlier, and we very much appreciate what you as a board have done for us.
So now that it's Rob one more time. So now that you've heard from Jim Graves, who's of course our incredible Executive Director of Respiratory Services, I think it's also important to point out that he has also been recognized for his outstanding efforts here at JPS, especially around the pandemic, as a healthcare hero here in Tarrant County. So a really exciting and appropriate recognition for an outstanding contributor here at JPS. So, Jim, thank you so much for your presentation. Thank you for your innovative ideas, for your fantastic leadership of an incredible group of respiratory therapists who have been truly doing yeoman's work through this very, very difficult pandemic. And so we are all deeply grateful to you and your team.
Well, thank you for the kind words, and I just want to echo that I have an absolutely amazing team. Thank you.
Jeepers, just outstanding work. Anybody else have any comments, questions for Jim?
I think Jim should be on Shark Tank soon.
Shark Tank. I've never seen that program. You'll have to tell me about that one, DT. All righty. That's it for the agenda, except for closed session and executive session. We have a little bit of stuff to talk about. You guys want to take a break or keep going? How about raise your hand if you want to keep going. There's 1, 2, 3, 4, 5. Yeah, we'll keep going. All righty.
Okay, Dr. Weber, give us just a
Executive
couple
session.
seconds to, hey, Dr.
And
Weber,
then let
give us a couple
David
seconds
do
to get the
the
stream
countdown.
down, and then I'll let you know when we're ready, okay?
I can barely hear you, David.
I said, give me just a moment to take the stream down, and then we'll come back and closed, okay?
Okay.
2, 1, you're back live.
Okay, I'd like to reconvene in open session for deliberation and or action deemed necessary regarding any matter on the closed session agenda, which is privileges.
Thank you, Dr. Weber. I'd just like to make a motion to approve the memorandum of privileging as presented in the executive session.
Second, Steve Simmons.
Is there discussion? Anybody? All in favor, please say aye.
Aye.
Those opposed say no. Motion passes. I don't have anything else. Does anybody have anything?
No, sir. I think you're good unless it comes from board members, but staff-wise, you are good.
All right. And, have a motion to adjourn.
This is M. So moved.
Okay.
Second.
Thank you, everybody. I appreciate it.
Thank you all.
Thank you. Bye-bye. Stay safe. Bye.